Good afternoon, everybody, and welcome to another IPC Partners Journal Club. Delighted to have John on today to talk about a really interesting paper. We're going to be talking about economic evaluation of enhanced cleaning and disinfection of shared medical equipment. I'm personally really excited for this journal club because it's a follow-on paper from a study that I followed really closely a couple of years ago, which is the Clean study in Australia, looking about whether or not shared medical equipment plays a role in the transmission of infections and what happens if you clean them more frequently. Before I pass over to John, John and I were just going to have a bit of a recap. This is the last journal club for 2025. So we thought, why not kick off with a little bit about what we enjoyed the most from Journal Club from 2025. So John, what was your favourite Journal Club?
Hi Phil, hi everybody. So my family often laugh at me because pretty much every meal I ever eat, I always say it's the best meal I've ever had because I just can't really remember before then. So true to form, I'm going to say the best journal club I've ever had was the most recent one, which was the IPS collaboration we did last week about behaviour change. I did look at all of them and I did genuinely choose that one. It's not only because it's the most recent one. I just think because behavior change is just such a critical part of what we do, and we just don't really have the skills or knowledge to do it properly.
Good choice. I enjoyed that one as well. My favourite one, looking back over the past catalogue, was Alexandra Peters talking about the Clean Hospital Initiative and the systematic review that she talked about, looking at the different interventions and just really cementing a lot of the thing that you and I have been talking about for the past decade, which is that environmental cleaning is really important, that the environment clearly plays a role in the transmission of infections. I also really enjoyed the IPS one that we collaborated with the team there around making infection prevention live. And it was that debate of whether or not it was live or lived. Trying to
Yeah.
bring that, so it ties in nicely with the behavioural change bit as well. Okay, thanks, John. Before we pass to John to present, for anybody who's new to Journal Club today, we always start with a little bit of an introduction to why we are here. We've got some useful QR codes as well dotted through the presentation today to help you to look and get more information about IPC Partners and who we are, but also about some of our exciting new initiatives that we are developing for 2026. So we always talk about a topical IPC published paper, and that's usually done by John or I or a special guest. Ideally, though, it's all about generating discussion. So please do use the chat box if you've got any comments or any experiences you'd like to share. And if you have any questions for John or I at the end, then please use the Q&A. If you can't see it in your Teams bar at the moment, it's just under the more three dots where you can open up more actions. We like to think that we are exercising critical thinking and building opportunities for CPD as well. We'll talk about an initiative we have for our webinars for next year, which are CPD accredited. And we'd like to think that we're building an enthusiastic network of people who are interested in IPC and evidence. And ideally, we don't want to take ourselves too seriously and have a little bit of fun as well. We record all these journal clubs. Your cameras are off and you're all muted, so you can't be seen, but we put all the recordings onto our YouTube channel. So please do share them with colleagues or people who are interested in the field. So John, without further ado, I'll pass over to you and I'll see you on the Q&A.
Okay, brilliant. Thanks, Phil. So today we are talking about a study which was an economic evaluation of a previously published cluster randomized controlled trial, which was called the Clean study. Now, I did a live poll at the Healthcare Infection Society FIS meeting a couple of weeks ago, and I asked the audience of 4 different interventions related to IPC, which had the strongest evidence scientifically backing it. And I chose hand hygiene, I chose environmental cleaning and disinfection, I chose antimicrobial stewardship, and I chose screening and isolation. And of those 4, the audience overwhelmingly chose hand hygiene as having the most evidence behind it. Now, I disagree with that, because if you look at the published literature and do a search for randomized controlled trials around infection control, it's actually cleaning and disinfection that comes out as top. That's got the most, the highest quality of evidence backing it up. I'm not talking about which we should prioritize or where our investment should be. That's a different question. But just in terms of pure scientific evidence, environmental cleaning and disinfection, in all its guises, has the most evidence behind it. So there's no doubt in my mind that improving environmental cleaning and disinfection absolutely translates to reduced healthcare-associated infection and reduce the transmission of antibiotic-resistant bacteria. However, that being said, there is a lack of good quality economic evaluation of interventions around cleaning and disinfection, or really any other intervention in the IPC sphere. So this article that we're talking about today is one of the first to thoroughly evaluate the economic outcomes related to an intervention around hospital cleaning and disinfection. So just by way of background, before we get into today's study, there are a couple of studies that have looked at the economic impact of an environmental cleaning and disinfection intervention. The most compelling of these is based on the REACH studies. This was a randomized controlled trial of a cleaning bundle to reduce healthcare-associated infection in Australia. The bundle cost around 350,000 Aussie dollars and generated around half of that in cost savings. Taking account of the infections prevented, there was a net monetary benefit of around £1 million Aussie dollars and an incremental cost-effective ratio of around 4,500 Aussie dollars per quality gained. And there was an 86% chance that the bundle was cost-effective. We'll come back to what that means a little bit later. So this was really positive. It was a nicely controlled, well-conducted, cost-effectiveness analysis that showed that a cleaning intervention was cost-effective, and that's a nice basis for today's study. A slightly older study with a less robust methodology was conducted up in Scotland by Stephanie Dancer's group, and they modelled the impact of an extra cleaner in a 12-month ward crossover study. The cleaner cost £12,000 per year. I mean, that is a story in and of itself. If you work in the UK, you will know that a salary of £12,500 per year is not a lot. And each MRSA infection was assumed to cost £9,000, which is a rough estimate. So MRSA infection reduced by 27%. And so there was an improvement in the financial position from in the region of around 30 to 70k. So this was a cost-saving intervention. So there is some evidence going into today's study that cleaning and disinfection is cost-effective. Okay, so the cleaning study itself. So this was the cluster randomized controlled trial that was used as the basis for this economic evaluation. It was a step-wedged cluster RCT trial of implementing an additional 3 hours of cleaning focused on shared medical equipment per ward per day. So there were two main headline findings. The first was that there was a significant reduction in healthcare-associated infection from around 15% in the control phase to around 10% in the intervention phase, which was a 34% reduction, and that was statistically significant after adjusting for potentially confounding variables. The other major finding was that there was a significant improvement in the thoroughness of cleaning as judged by the removal of UV fluorescent markers, and you can see this in the bottom panel of the charts on the left. So this increased from 24%, which is a bad low level to begin with, perhaps even worse than you might think. Some of the baseline estimates for this kind of study have been more in the 50% bracket, and that improved to around 66% in the intervention, but still 1/3 of surfaces not cleaned even in the intervention phase. So the methods for the economic evaluation were based on this step-wedged cluster randomized intervention trial, which was done in a 10 adult acute wards in a tertiary hospital in Australia, a total of just over 5,000 patients. And the intervention was this multimodal cleaning bundle, which included the dedicated time, but also some education and audit and feedback as well. And the analysis, this is where it can get a little complicated. I'll try and make it as straightforward as possible. I'm no statistician, okay? So no difficult statistical questions, but I hope I've got at least a rudimentary understanding of the methods that we use. So this was a decision tree model. From a hospital costing perspective, they undertook an incremental cost effectiveness ratio analysis, and they did some Monte Carlo simulations in order to understand the likelihood that the results they were seeing were real. And I'll try and explain what that means later. So the results, they very helpfully equalized all of their results to as if there was 5,000 patients. So rather than, as if there was 1,000 patients. So rather than doing it for 5,000 patients and having to work back, they broke it down to per 1,000 patients, which is helpful, I think, as a measure. So the intervention costs were 1.5 million Aussie dollars versus 2.1 million Aussie dollars for usual care, so a saving of 642,000. Now, on the face of it, that perhaps doesn't make sense because obviously they were spending money on the intervention, but these figures are accounting for the savings associated with reduced healthcare associated infection. So in the usual care arm, i.e. no intervention, there were 130 healthcare associated infections versus only 100 in the intervention arm, and this is per 1,000 patients. So the intervention avoided 30 infections per 1,000 patients and 384 excess bed days as well. Now, the probability of cost effectiveness. So this is where we get to the Monte Carlo modelling. So they didn't just run one single linear analysis. They ran an analysis multiple times using the same data as inputs, but with some statistical variability in there to try and understand variation around those variables. That simulation found that there was a 90% chance of the intervention being cost effective at a $0 willingness to pay. So that means if you spent no money at all, then there's a 90% chance that this intervention was cost effective. If you were willing to pay up to $20,000 per avoided infection, then there was a 99.9% chance that this intervention was cost effective. So you need to understand that in cost effectiveness analysis, there's usually a willingness to pay threshold because there's a recognition that healthcare improvements usually cost money. They're not usually free. So this is a slightly backward study because it was actually a cost-saving intervention. The more you did it, the more you saved. Whereas if you were investing in an expensive drug, say, you'd have to spend money on the drug in order to see the benefit. So that's why we have this willingness to pay threshold in cost effectiveness analyses. The other part of the study is they ran two different scenarios on top of the data. One was using a biodegradable wipe, which is more expensive than a standard wipe, and one using halving the level of effectiveness attributed to the intervention. And in both of these scenario analyses, the intervention was still cost effective. So let's look at those findings in a visual way. This is a standard way to show the results from a cost effectiveness analysis. So on the x-axis at the bottom, we have the incremental effectiveness. So on the left is bad, the intervention isn't working. On the right, it's doing good. And the incremental cost above the line on the y-axis, it means it's costing money. Below the line means it's saving money. So that bottom right quadrant means that your intervention is both effective and saving money. So it's cost beneficial. So what you're looking for is an intervention to either be in that bottom right cluster or that top right cluster where you have to spend some money, but it's still effective. The interventions you really don't want to see are on the left-hand side of a chart like this. This is a plot of the Monte Carlo modelling to look at the cost effectiveness acceptability curve, looking at the probability that the intervention was cost effective with usual care versus the intervention. And you can see that even with a zero willingness to pay threshold, if you're not willing to spend any money, there was still a 90% chance that it would be cost effective. If you went up to 10,000, 20,000, it quite quickly became almost certainly cost effective. Now, this is important, these two scenarios. So the biodegradable wipes scenario is perhaps less important for reasons that we'll come on to later if there's time. But scenario 2 is important because if you remember those reduction figures, the healthcare associated infection prevalence was 15% at baseline, 15%. Now that's high. In the latest UK survey of healthcare associated infection, it was around 7 or 8%. So almost half, and more than double the rate we'd expect to see in the UK. Maybe some interesting complex reasons for that, perhaps the specialty of the wards that were chosen. Even after the intervention, the healthcare associated infection rate at 10% was still higher than we'd expect to see. So I think the second scenario where the effectiveness of the intervention was halved is actually quite important for understanding how this intervention might perform in a setting where the prevalence of healthcare-associated infection is lower. So you can see on the bottom line of this table, the intervention, the cost of the intervention accounting for the reduction in healthcare-associated infection was still fairly significantly lower than the usual care costs. So the usual care costs were $2.1 million US. The intervention costs were 1.7 US Aussie dollars, accounting for the reduction in healthcare-associated infection. So it was still a cost-saving intervention, even if the effectiveness was halved in the modelling. Okay, I hope that was clear. I am on the edge of my knowledge and understanding when it comes to economic evaluations, but hopefully that's got across the key points from this study. So this was a strong economic evaluation based on a rigorous study to begin with. So both the original study and the economic evaluation itself used strong and appropriate methods, including this probabilistic sensitivity analysis with the Monte Carlo modelling to tell us not just what happened when they ran the model once, but what happened when they ran the model multiple times, to give us an idea of how this might land in the real world. They also used a hospital perspective for their analysis, which is most helpful for somebody like me who works in a hospital, is making a decision from a hospital point of view, maybe less relevant for somebody working at a more community-based level, thinking about what a healthcare system may do, where you may want to include societal benefits and quality adjusted life year costs. It was a single site intervention at the end of the day, so that may limit generalizability. There was some conservative assumptions in there, so they only allowed one healthcare associated infection per patient, which is often not true. And as I've mentioned, the rate of healthcare associated infection was high to begin with, so that may limit the generalizability as well. So points for discussion. Based on the study, the CLEAN study, and this cost effectiveness evaluation, should we invest in dedicated resource targeted at cleaning and disinfection of shared medical equipment? Is it time to put our hands in our pockets here? If so, what would be the best model of doing this? Do we fund a new post whose job it is to sit in an equipment room and disinfect shared medical equipment all day? Or do we attach this to the pre-existing roles, perhaps? Should IPC guidelines now mandate structured cleaning bundles for shared equipment? Should we audit the cleaning and disinfection of shared medical equipment? Not something we've done historically. And what about the biodegradable wipes? Is that something that should be considered? Bearing in mind they also came out as not only cost effective but cost saving in the scenario analysis as part of this evaluation. So finally, before we go back to Phil and to hear your questions, what does this mean for IPC? Well, the CLEAN study is really strong, compelling evidence that enhanced cleaning and disinfection is not only clinically effective, but probably cost saving and almost certainly cost effective. And I think for IPC teams, it reinforces the need to prioritize cleaning and disinfection of these shared medical equipment items, and it's a really nice horizontal intervention. So if we get the cleaning and disinfection of shared medical equipment right, we're going to be reducing our risk of C. auris, of C. diff, of norovirus, of MRSA, of all kinds of environmentally associated potential hospital pathogens. So with that, thank you, and Phil, back to you.
Thanks very much, John. Did a really good job there of talking through some real difficult economic analysis, which isn't easy as a healthcare professional, is it? It's a really impactful study, isn't it? And I think it builds really nicely from the previous work that they've done. There's a couple of questions already, John, but maybe if I can just kick us off. Where do you think CLEAN as a study and then this subsequent economic analysis rank in terms of the evidence that we have for the importance of the environment and interventions and how they can make a difference in transmission of infection?
In terms of cleaning and disinfection studies, or in terms of studies generally?
Sorry, in terms of cleaning and disinfection, sorry.
I mean, top 10, definitely top 10.
Yeah.
I think the limitations of the study are not so much the design. The design was really good, but it's more about the setting. It was done in a single setting on 10 wards. So you can argue that it's not very generalizable to other kind of broad contexts, but also isn't huge when you compare it with some big cluster randomized controlled trials that were spanning multiple hospitals across multiple countries sometimes.
Good answer. So please do ask John any questions using the Q&A. Just building from that, do they talk anything in the paper about, future studies or future work and where it might go next?
I mean, always that's you have to say that, right? What does this tell us about future work? They do, and I think they're calling for bigger studies and more cost effectiveness evaluations. But yeah, for me, this is maybe becoming more about implementation now. Do we need more data on this point? Perhaps we need some more generalizable findings of the initial data that fed this analysis, but the cost effectiveness evaluation is pretty compelling.
Agree. Okay, let's get into the questions. Sangam asks, since the intervention was a package of different actions, like extra cleaning staff, training and auditing, which single component was the most important for achieving the cost savings and reducing HIAs? This might help to focus the resource efficiently to maintain the cost saving.
Oh, it's like doing your GCSEs. I think the answer is in the question there. So since this is a bundled intervention, we can't say with any certainty which element of the bundle was most important. So the answer to the question is we don't know. It could have been any of those items of the bundle. It could have been a combination of factors within the bundle. If I was a gambling man, my money would be on the additional time allocated to the task, because that's the thing that probably unlocked the most potential to improvement. Because we really struggle to find time to do pretty much any task in healthcare, don't we? But particularly a task like cleaning disinfection, which is often seen as a bit of a Cinderella task. So I think if you look at the elements of the bundle, we had the extra time, we had the education, and we had the feedback loop. So I think probably it's the extra time feels like the biggie there, followed by the feedback loop, followed by the training. But as I said, we don't know for sure.
Yeah, I'd agree. And I think, the important thing is that they all complement each other. You're giving people or you're providing the resource to clean the equipment in the first place, and then it's kind of a continuous improvement program, I guess, to use the feedback and the audit to kind of improve that. And what I'd hope would be that you get to a really high level of compliance, and then that becomes maintained because people become, more familiar with what good looks like and the do's and don'ts and principles of cleaning, etc. So it's a good question, but like you say, impossible to pick out one single area. And that's a challenge with infection control in general, isn't it? When we're doing studies, trying to talk about, how do we make sure that hand hygiene compliance and antimicrobial prescribing all stays the same while we're doing our intervention. Okay, Barbara asks, what about the balance between more frequent cleaning and potential harm to equipment, surface/degradation, and reducing the life of equipment? That's a good question. So trying to understand material compatibility.
Yeah. So I think the shared medical equipment needs to have cleaning and disinfection after each usage. And if the equipment is not up to coping with that, then it's not designed right. It's not fit for purpose for use in a healthcare setting. So if a piece of equipment is not robust enough to withstand the level of cleaning and disinfection, the minimum standard that will be required for its use, then that's a design problem. There may be some questions around the kind of agent we use. We know that chlorine-based agents can be have more compatibility issues than others. So I think we do need to think carefully about which agents we're using. And as ever, we'll be looking to the manufacturer instructions to guide us on what an appropriate cleaning and disinfection agent should be. But I think fundamentally, a piece of shared medical equipment needs to be disinfected each time it's used between patients. And
Yeah,
it needs to be able to withstand that.
yeah, I think I'd agree with that. Maybe just building on that then, do you think there's a role for manufacturers of equipment to be really clear in terms of not just the way that they design and make, but and being able to withstand it, but also in the guidance they give? And I think,
Absolutely, yeah.
so is there a sweet spot between the manufacturer of the cleaning and disinfection products and the manufacturers of the equipment?
I think there is. I think it's a challenge, and I feel for manufacturers because it's easy for them to give very conservative cleaning and disinfection advice, i.e., use the most gentle detergent you can possibly find, and it's good for a baby's skin, which is safe for them and good for their equipment, but actually not very useful or very workable in a hospital environment where we need to be using disinfectants on some of this equipment. So I think there's an opportunity for some dialogue as well, and not just leaving a manufacturer in isolation to make recommendations about disinfection, but actually to work with them so that they understand our challenges, and we can sort of work together towards solutions that are really practicable.
Yeah, I completely agree with that. I can remember when I was working in IPC in an acute trust, and we were reviewing some cleaning and decontamination uh, for something quite dangerous in terms of risk of transmission. And the recommendation from the manufacturer was a bucket of warm soapy water.
Yeah,
So no,
yeah,
yeah, no disinfectant, and no single use either. So the alarm bells were ringing. A comment
completely.
from Go on,
Can I just go back to you on sort of both of these questions about the sort of cleaning frequency of these devices? Because in some ways, the clean study, as much as I love it, was actually a fundamentally flawed design. Because if you think about it, this is shared medical equipment that's used on multiple patients. And the way that it should be used is you use it on a patient, you disinfect it at the point of use, and then you use it at the next patient. Whereas the model in this study was to kind of collect all the equipment together and disinfect it once a day. So in a way, this isn't quite the right model of implementation for the kind of ideal disinfection strategy that we want to apply.
So if you had a crystal ball and they did decontaminate in between every patient use, do you think that the clean study would have shown an even greater reduction in infection?
That's a really unfair question. Because it's unfair because I think the scale of the reduction in healthcare associated infection in this study was on the edge of biological plausibility. Like, I'm a believer in environmental cleaning disinfection. I really do think it does have impact in reducing cross transmission. Do I believe that 35% of healthcare associated infections are traced back to shared medical equipment? That feels a stretch. So to say that even more than that might be true in reality, I'm not sure that is true. My again, we don't know, but my hunch is that the high baseline healthcare associated infection rate sort of artificially inflated the impact of the intervention.
Understood. We've got loads of questions, John, so I'm going to move forward with speed.
Great.
Yassine asks, was extra staff time cost included in the cost effectiveness analysis?
Yeah, absolutely. Sort of fundamental to it. So they really wanted to capture that.
Excellent. I think that builds really nicely into a question from Gail. Do you think that HCA reduction is the outcome driver to use to get executive support, RE cleaning budget to achieve outcomes as cost savings in pounds mentioned in grey money as none changes hands? So yeah, whether or not HCA reduction is the right measure to try and drive extra support from the execs to talk about cleaning budget. And I guess staff would fall into that budget as well.
That's a really, really good question. And I'm pleased you raised it because I did mean to mention this. I went through and I forgot. So thank you to Gail for picking this up. So let's try and unpack the question a little bit. So is healthcare associated infection the right metric to convince the board? So what this study is saying is that for each healthcare associated infection, there's an associated cost, and we can attribute that cost to extended length of stay, to drugs, to other diagnostic tests they require, laboratory costs, etc. But the problem with that cost is that the questioner described it as grey money. It doesn't change hands. And that's true because you've already committed to running a hospital with a certain number of bed days. If you have somebody stay with a healthcare associated infection, often that means nothing compared with a new admission in that bed, depending on where you work in the world. So it can be quite hard to make these paper-based costs of healthcare associated infection mean something in real hospital budgets. So I don't think the pure cost of healthcare associated infection is the right metric, but I do think that increases in bed days is much closer to the kind of metric that's going to convince trust boards, because operational flow through a hospital is absolutely critical. If you end up with a clogged A&E, if you end up with medical patients in surgical beds, so you can't do your planned procedures, or if you end up with outlying healthcare associated infection rates, those are the kind of metrics that will begin to convince boards that we need to intervene and pay to intervene to improve these outcomes. I think the other thing to add to that is quality of care is a really powerful driver. We talk a lot about cost and cost effectiveness, and it's vital, but actually intervening in such a way that we improve the quality of care by reducing healthcare associated infection is something that is a powerful metric at a board level.
Yeah, really good response and a really good question. I definitely agree. Flow and capacity in the organization is a good point to hang it on. And working in IPC, we all know that infections are bad news for those type of things in the organization. Just a comment from Lisa: manufacturers should be outer casing that can stand multiple chemicals used in decontamination. Completely agree, Lisa. So just cycling through the list, Miranda says, is there any hospitals that we know of that have implemented this in the UK? I think the answer is no, John.
Yeah, I don't know of any that have implemented this kind of approach where you've got dedicated cleaning resource to focus on shared medical equipment. There was the Stephanie Dance study to employ an extra cleaner. I don't know whether that was sustained or not, but no, I've not heard of anybody implementing it. So let us know if you have. Be interested to hear.
Yeah, I'd love to see that. Okay, another question from Sangam. Even though the data collector was blinded, the cleaning staff were aware that they were being audited. Do you think that this played a role through the Hawthorne effect and then have an effect on the outcome? And has there been any follow-ups to see if the changes that they've observed have been sustained? So talking about whether or not there's that kind of Hawthorne bias, John.
Yeah, I mean, observer bias where performance improves when somebody knows they're being monitored, so also known as the Hawthorne effect, is a pretty powerful driver in our psyche. So I have no doubt that observer bias was a factor in this study, and that the improvements in spot removal may have been due to the kind of the incubator of the study. From the clinical outcome point of view, that's great, and we take it because we want compliance with the intervention to be really high so that we can know whether the intervention made sense. But from a kind of ongoing implementation feasibility point of view, it's a challenge. So I don't know what happened next in this hospital, whether they retain the intervention or whether they stop the intervention. My suspicion, based on a conversation I had with Brett Mitchell, who was the PI for this study, was that they didn't carry it on because I know they had trouble with recruitment of staff to do this job, even in the study period. And you can understand it, can't you, Phil? Would you want to sit in a darkened room without windows, disinfecting medical equipment for an 8 or a 12-hour shift every day?
If I could listen to Christmas songs on repeat. No, it is a really good point, isn't it? But I guess my challenge to that would be look. I'm on the same page. I think that it's a really important study, and it's showing kind of how shared medical equipment can play a role. But can we not build this into our existing cleaning professionals' role? Rather than giving it just to one person, could we maybe have this as an extension of duties so it's shared and it doesn't become, mundane? These professionals within our organizations have got a great deal of skill, and I think they're undervalued. I've heard people talk about making cleaning a science and a profession. So I think, there's a balance to be had potentially between now we're seeing more and more the evidence and the importance of these things and their role in transmission. Can we not kind of elevate the skill and the workforce that goes with it to really highlight just such an important role that our cleaning professionals and domestic teams play?
Yeah, I do. I like the idea of attaching this to existing roles. I think that's the way to do it, because I really don't think that JD is one that you could recruit to. They're kind of sitting in a room all day disinfecting equipment, but adding it on to as an additional part of several roles, I think makes a lot of sense. But it doesn't get us around that problem that this isn't the best model for deployment. We really want to be disinfecting these items of equipment at the point of care after they've been disinfected. So is there a way we can take that 3 hours of time that's funded and use that to prompt clinical staff or the users of this equipment to do the disinfection in situ? That would be the nirvana here. I'm just not quite sure how to get there.
Yeah, I mean, I was going to ask you, how do you measure that, and how do you kind of audit compliance? And really difficult to do when there's so many opportunities for shared medical equipment decontamination.
Yeah, well, I don't know how to get it improved, but I think we can. It's something we can audit. It's not something we've traditionally audited. If you're an infection prevention practitioner, going off into the ward, what are you going to audit? The built environment commonly, but more about the structural aspect, hand hygiene performance most commonly. Spend a lot of time doing that. We don't tend to observe the disinfection of shared medical equipment after it's been used, aside from a kind of incidental observation. So I'd love to see more systematic auditing of disinfection of shared medical equipment at the point of care in a way, in a similar way than we audit hand hygiene.
I agree. And we've got automated hand hygiene technology. I'd love to see that being applied to decontamination of shared medical equipment. Can we use AI, cameras, anonymizing people, obviously, to look at all the opportunities for shared medical equipment decontamination and see what the compliance rate is? Do you think it's low currently?
Yeah, I would say it's low. Yeah, I think it, yeah, I think often it just wouldn't get done. It would be bottom of the list. And it would just be forgotten. And it's not something we actively promote. We actively promote hand hygiene all the time. Do we actively promote shared medical equipment disinfection? We do. I'm not saying we don't ever, but I don't think it has as much focus as something like hand hygiene.
Yeah. I'd love somebody to go and do a study with that. Go and do an audit, of opportunities or an observation on opportunities for medical device decontamination or shared medical equipment. Okay,
The five moments for medical equipment disinfection.
you're onto something there, John. Um, I think this is a comment more than anything from Lisa. How do you measure infections that have been prevented as they didn't happen? Systems don't monitor all infections. Don't know if you want to comment on that, John.
Yeah, it's a problem, isn't it? I suppose the answer is through a statistical model that shows you a curve of what should be there and what isn't there. So it's a statistical measurement rather than an actual observation.
And another question from Gail: are nurses and clinical staff the best place to do the cleaning when their priority is clinical care?
Yeah, I see this as a part of clinical care, and it should be seen as that. Some clinicians do get that. Some doctors and nurses and other healthcare professions really take a lot of care and attention and are advocates of cleaning equipment and the built environment generally. Others, they just don't see it as part of their role. They see it perhaps as a nursing role or as an unregistered cleaning professional role. So I think that's part of the problem, that it's not seen as part of that core clinical function.
Yeah, I agree. And it's about trying to, I think we touched upon it earlier, and integrate it into the more daily routine and daily practice. And it's about trying to find that balance ultimately. Okay, last question, if that's okay, John. It's always difficult to not want to answer them when you know the answer. Tariq says, did the clean study implement the use of automated cleaning technology? And if so, which were the most used and cost effective?
So the clean study, as far as I was concerned, was just this multimodal bundle. So it was the additional hours of cleaning, it was the training and education, it was the feedback loop with the fluorescent markers. I don't think there was any sort of automated disinfection technology that was implemented at the same time.
Yeah, I think you're right. What's the better study might be something to point Tariq to, which is the benefits of enhanced terminal room cleaning.
Room disinfection, the better D study.
Better D study, yeah, which looks at UVC.
Yeah.
Okay, Thank you all so much for your questions. It's always great when we get lots of Q&A because it generates a lot of discussion and it keeps John on his toes as well. So we're really excited to launch a new program for 2026. We've been doing journal clubs now for almost 18 months where we focus on kind of one key paper. We're moving to a slightly different model. Journal Club will still run, but we will be twinning it with our Insight webinars. So our first one is in January. We've got a really exciting schedule in partnership with the Infection Prevention Society and the Healthcare Infection Society for next year. So our first one is in January. Where we'll be talking about can the Zyma auris, the infection control challenges in Kuwait with Dr. Arej Ali Al Ali. Next slide, please, John. You can see the schedule of all our journal clubs and webinars there. So if you want to have a quick scan of that QR code on your phone, that'll take you right through to it. And then last but not least, you can see all of our previous journal clubs and Insight webinars on our YouTube channel. Is that our last slide, John?
Yeah.
It is. Okay. John, thank you very much. Really good presentation and great insight as always. Thanks to the audience. Thanks to everybody who's participated in IPC Partners in 2025. I think John and I both wish you a really merry, happy holidays, festive period and a happy new year. And we really, really do hope that you get involved with everything that we're building for 2026. Any final words, John?
No, thanks for coming. Thanks for all the questions. I mean, these journal clubs and the webinars in 26 are going to be founded on the questions that we get from the audience. So please keep them coming. Yeah, we'd love to see you.